Good afternoon, everybody, and welcome to PD 101. This is our third module of a 3-module segment, and this one is on exercise as medicine. So we have a couple of great speakers for you today, and we're going to start with Lyndsey O'Keefe, who is a PT, and I'm going to let her give you background. But she is going to talk tonight about exercise as medicine. So Lyndsey, give it away. Oh, before I do that, very quickly, I do want to remind you, there is a way to ask questions while Lyndsey is presenting. And that way you don't, if you don't want to forget them, you can type questions on your panel. You'll see a questions panel on your right-hand side. You can type your questions in there as Lyndsey is speaking. We're going to hold questions until the end and ask them all at one time. And the other way that you can ask a question at the end is you can raise your hand and I will be able to unmute you. And then you could ask your question live. So if you have a question while Lyndsey is speaking, please go ahead and type it in so you don't forget it. And we will answer those at the end. There are also a number of handouts that you can download, and they're on the right-hand side of your screen as well under handouts that have class list and other really good information for you. So now I will let Lyndsey take it away. Go ahead.
Hello, my name is Lyndsey O'Keefe. I'm a physical therapist and I specialize in neurologic rehab. So yeah, we'll talk about how exercise is a form of medicine as more of a general concept, but of course specifically for as it relates to Parkinson's disease. A little bit more about myself. I have a doctorate in physical therapy. I'm a board certified clinical specialist in neurologic physical therapy. I'm a Power Move certified therapist, which is specifically for the treatment of Parkinson's disease. And I practice in Boulder at Pace West Physical Therapy. And I'm also a lab instructor in the neurologic program at the University of Colorado at Anschutz. I'm new to Colorado and I'm still learning how to say that word. I also teach in the doctorate of physical therapy program at University of Colorado. So today we'll talk about a little bit about Parkinson's disease, mostly how it affects movement. What does the research say about exercise? What kinds of exercise and how much should you do? And how you can get started with a little bit at home after today's program. All right, Parkinson's disease and movement. Parkinson's disease affects the basal ganglia, which is highlighted here in that image of the brain. It's in the midbrain, and the disease process ultimately is a decrease in dopamine, which is a neurotransmitter or the chemical that your brain cells use to communicate with one another. And what that basal ganglia part of the brain is responsible for is motor control, meaning it doesn't really control strength necessarily, but more about how you use that strength, how you initiate movement, how you choose the right amount of movement, the amplitude, and how you stop movement. And so the 4 key symptoms of Parkinson's disease, and of course there are many, but the 4 cardinal symptoms are bradykinesia, which is slow movement, rigidity or stiffness, tremor, which is in Parkinson's disease a resting tremor, and postural instability or imbalance. You can have any number of these 4 symptoms, and like I said, lots of other secondary symptoms can very often accompany Parkinson's disease. All right, so exercise is medicine. Parkinson's disease is a decrease in dopamine, and exercise increases dopamine. It's that simple. Exercise is also neuroreparative, meaning as neurons degenerate, exercise can help repair those synapses or those connections between the brain cells. And this can happen through the increase in a compound called BDNF, or brain-derived neurotrophic factor. There's no quiz on this at the end, don't worry about that. This chemical BDNF helps repair those damaged synapses by sometimes creating more, sometimes just strengthening the ones that are weakened. It is neuroprotective, meaning it can help protect the remaining brain cells that have not yet been affected by the disease and protect them from being either affected at all or as affected as the disease progresses. Exercise is great for cognitive and emotional health. And this is true for everybody. So if you have a caregiver or a family member who's trying to encourage you to exercise, get them to join with you, because it can help their cognitive and emotional health as well. Secondary deconditioning is something that often occurs with Parkinson's disease because movement becomes harder. And if movement is harder, you tend to do less of it. And so, as I mentioned, the basal ganglia doesn't necessarily affect strength. However, if you move less, you spend more time sitting or sedentary, then you are going to get weaker because of that. And so exercise can help with that secondary deconditioning. And a lot, especially if you come see someone like me, a physical therapist, that exercise is going to be focused on function. And so it's ultimately what's important to you. We can work on strength, but I want to know, why are we getting stronger? Is it to help you get out of that chair a little easier? Is it to help you get on the floor to play with a pet or a grandchild? Or to be safer walking outside in your garden? There's lots of reasons people want to get stronger and have better movement. And if you're working with a rehabilitation professional, we can focus specifically on those issues that you're having. So general exercise guidelines are listed here. So there's different types of exercise. There's aerobic exercise, or the cardiovascular. It gets your blood pumping. The general recommendations, and these come from the American College of Sports Medicine, so this is general again for everybody, not specifically for Parkinson's disease, is 150 minutes of moderate intensity per week, or 75 minutes of vigorous intensity. We'll talk a little bit more about what that moderate and vigorous intensity might look like in a later slide. But 150 seems like a big number, but I break that down for patients as, if we think of it spaced over a whole week, it's about 30 minutes a day of moderate intensity. The nice thing is you don't have to do it every single day. You can, if you are someone who are just a weekend warrior and you want to get all those 150 minutes in on Saturday and Sunday, go for it. It's the same benefit as if you did it every day. Strength training is anything that strengthens your muscles. So something where you're using your muscles against resistance. And resistance might just be the weight of your own body. It might be lifting a weight in a gym. It might be using a stretchy band. There's lots of ways to strength train. And you want to do that at least 2 days per week. Balance, a reason a lot of people come see me, is anything that helps to reduce the wobbling, get you more steady on your feet. That should be done by these guidelines at least 3 days per week. If you come see me, I'm going to recommend more than that. A little bit every day for balance is really, really helpful. Flexibility, again, a little a day goes a long way. You want to stretch a little bit, get those joints more fluid. Something we say in physical therapy a lot is motion is lotion. So the more you move those stiff joints, the looser they get. Aerobic exercise, again, anything that gets your blood pumping, gets your heart working a little bit harder. And so what kind is the best kind, or what kind is, do I recommend is anything that you can do safely, anything that you like to do so that you'll do more of it. And so coming back to this moderate or vigorous intensity, if you check over on the right hand of the screen, this chart is also in the handouts that was referenced at the beginning. So you can print this off, put it, take it with you if you go exercise somewhere, or if you exercise at home, stick it on the wall and look at it while you're exercising. Make sure you're keeping up with that intensity level. Moderate would be a 5 to a 6 on this chart. So somewhere around, I'm just above comfortable, I'm sweating more, but I can still talk easily. Or I can still talk, but I'm slightly breathless and definitely sweating. I tend not to focus too much on sweating because people sweat very differently. For right now, with this hot weather we're having, just standing outside, I'd start sweating. And so it's not necessarily moderate intensity exercise. But the breathlessness is a really great, or the amount of breathlessness is a really great cue for yourself as you're working out. And so slightly breathless, but you can still talk, meaning you can get a full sentence out. You don't feel like you lose your breath by saying a couple words. The 75 minutes would be for vigorous intensity. So that's a 7 to 8 on this scale. And so the 7, as you can see, is I can still talk, but I don't really want to. So my example for that is if you had a family or friend that came and talked to you while you were exercising, and they said, "How are you doing?" And you could get out, "I'm okay." And that's about it before you really have to catch your breath. You're not going to tell them all about the run that you're going on, or you're not going to tell them what you had for breakfast. You're just going to answer their question and get on with it. Or an 8 would be you can grunt in response, but that's about it. And you can really only keep that pace for a short time. So if you think you're at an 8 for the entire 30 minutes of exercise, you might not be. But doing interval training, trying to work up to a 7 or 8, maybe just for 30 seconds, but then back to a 5 or 6, and back up to a 7 or 8, and back down to a 5 or 6, back and forth like that is just as effective as trying to stay at that 7 or 8. And that's really, I think, helpful for people to keep in mind that the idea here is not for you to be terribly uncomfortable, absolutely breathless for the entire time. But we'll talk a little bit later, or in a few moments here, about that intensity truly matters when we're exercising with Parkinson's disease. So we do want to at least try to get up to that 7 or 8, even if just for a short interval. Aerobic exercise needs to be at least 10 minutes in duration in order to get cardiovascular benefits. So that means walking, it might be vigorous. You might walk really fast to the mailbox at the end of your driveway and back to the house. But if that doesn't last at least 10 minutes, it was good practice. It's a skill to learn how to walk quickly, but it's not aerobic exercise. And so in terms of research for aerobic exercise in Parkinson's disease, more is better and intensity matters. More is better and intensity matters. You're going to hear that a lot again if you work with a Parkinson's specialist, if you come to see me, and that's because the research clearly indicates that these are true. So what they did is how they know that this is true is they took mice in a lab and they essentially induced Parkinson's on them, and then they put them on treadmills and they looked to see what happened to those regions of the brain, that basal ganglia, when depending on the level of exercise, the amount of revolutions on the treadmill, or the speed on the treadmill, their little mice treadmill, that they were running at. And basically they found that the faster the revolutions, the more revolutions that those mice ran, those mice were more protected from the disease process of Parkinson's. And the other mice, they still had, because they exercised, they still had some protection. But again, that mice that did more had more protection. And then intensity, they actually did human trials. So there's an outcome measure called the UPDRS, and your either neurologist or movement disease specialist may have done some of this with you or all of this with you. Basically, it's a score of how much Parkinson's disease is affecting you. How severe is this disease process in you? And it will change over time. And so they had patients exercise. They took their numbers before they started an exercise program, and then they had people exercise either kind of at that, at a moderate exercise intensity level or at a vigorous intensity level. And that's individual. Keep in mind that's not one person's vigorous exercise is not the same as someone else's. And that's the nice thing about using this chart. It's not about specifics. It's not run this fast, walk this long. It's how hard you feel you're working is how you determine your intensity level. So they took groups of patients. They had them either, again, exercise at a moderate level or an intense level. And the patients who exercised at that intense level had significantly better changes in that UPDRS score than people who exercise at a moderate level. Again, people who exercise at the moderate level still had good changes, better than the people who did not exercise at all, but significantly better if you exercise at a higher intensity. Strength training, again, should be done at least 2 days per week. I encourage patients to focus on functional movements. Sit to stand, a push-up, pushing something is an important skill. You might be pushing, a door open. You might be pushing a walker or a grocery cart. Marching is great, practicing picking up your feet. So that shuffling pattern is really common with Parkinson's disease, that your feet aren't quite getting up off the floor as much when you walk. So practice that exact skill of lifting your foot. It also strengthens the muscles that will help you do that. A typical dosage for strength training is 3 sets of 10 repetitions. I specifically say 3 sets of 10 and not 30 because you have to have an appropriate level of challenge in order to strengthen muscles. And if you can do 30 in a row and feel like, okay, what's next? It's probably not an appropriate level of challenge to really gain strength. Is it still good for you? Absolutely. Does it maybe work your aerobic capacity because you just did 30 push-ups in a row? Yes. But is it going to strengthen those muscles? Not as much as if you did 10, as if it was hard enough for you to only do 10 reps, feel like you need a quick break, like a minute or two, and then another 10 repetitions, and then another quick break. And if you can't get to that level, you feel like, I did 10, but that was no problem, I could do more, then you go for the next level of challenge. And that level of challenge looks different depending on what the exercise is. It could mean more weight. It could mean a lower surface you're standing from. And if you're not sure about that, again, there's exercise professionals to help you. Discomfort and fatigue is normal when you strength train. Pain is not. My general rule is to look 24 hours after you've done the exercise. Do I still feel like those muscles are painful? Then maybe I did a little too much. Or is my joint painful? Then yeah, probably a little too much. If I feel like I finish an exercise and man, that muscle really feels like it worked, but it gets better over that next 24 hours, that's perfect. That's what you want to aim for. Balance, again, the general recommendation is 3 days per week. I highly recommend you do more than that. Balance is a skill. And just like any other skill you want to learn, more practice will help you learn it that much faster. Balance is something that if you don't use it, you lose it. So that again is true for any aging adult, and certainly someone with a disease like Parkinson's. There are tons of options for balance. Balance does not need to look like this picture. It does not need to be standing on one foot. You can stand with a narrow stance, maybe instead of a big wide kind of John Wayne stance, you might bring your feet hip distance apart or closer. You might stand tandem or 1 foot in front of the other, like you're on a tightrope. You might try and stand on 1 foot. Your eyes could be open, but that's the easiest way because you get to use the environment to help you figure out how your balance is. You might try closing your eyes if it's safe for you. Or you might just look around so your eyes aren't locked in on something. They're called hanging on by your eyes. But you might just look around the room and see if that challenges your balance a little bit more, because that's real life too. We don't want to only be able to balance when we're staring straight ahead with nothing in our way. We have to balance while looking around the store, right? While talking to friends. If you're on a hike, you want to enjoy the scenery. You don't want to have to stay locked ahead of you. You can change the surface that you're on. So a firm surface is going to be easier than a soft surface. Soft surfaces are good to practice on though. If you have to walk across grass or snow, or even really plush carpet. Your hands can either be holding on, that can be holding on, tight with your whole grip. It can be maybe just resting your hand on top, maybe just one fingertip. You can have your arms out, like the tightrope walker. Or you can even try crossing your arms so that you don't use that counterbalance from your arms. You could also try and move your arms intentionally to throw yourself off a little bit. You can do all of these options are to make the exercise difficult but doable. That's the key for balance. Again, just like strength training, if I want to strengthen my bicep muscle here, I'm not going to just lift my own hand up and down. and expect to get stronger. It's not difficult enough. I'm also not going to go pick up the heaviest weight in the gym and try and lift it, because first of all, I'll hurt myself, but also it's just not possible. It's not doable. And so same goes for balance. If I want to improve my balance, I have to challenge it. But I have to challenge it in a very specific way that's still doable, because if I challenge it and immediately fall over, first of all, I could hurt myself. And second of all, I haven't spent any time learning the skill. I've just fallen out of it. And so again, finding something, my typical rule is 30 seconds. If you can hold something but wobble for 30 seconds, perfect. Keep practicing that until you no longer wobble. Then you move on to the next level of challenge. Flexibility. So daily mobility can be so helpful. As I mentioned earlier, as very early on, that one of the 4 key symptoms of Parkinson's disease is rigidity. We want to try and break through some of that with daily mobility and flexibility or stretching. Gentle holds is important. So you might feel a slight pull in a muscle. The goal is not to absolutely touch your toes or touch the floor or reach your hand all the way up overhead if that's not something your body is ready for. Excuse me. You want to feel a slight pull, very gentle, and then hold that position for 30 to 60 seconds. And that's what's really going to actually lengthen the muscle and change the resting state of that muscle to make it a little bit longer. For whole body movements, you know, moving your legs and your arms, working on posture, moving your spine, those are great too. So those are kind of like the good morning stretch, everything stretches up at the same time, or you do a full body twist. Those are great exercises, especially as a warm up before you go on that walk or ride the bike or do a strength exercise. And specifically when we're talking about rigidity and Parkinson's disease, rotation can be so helpful when that back feels really stiff. So we'll talk a little bit more about some of that, but again, just, you know, sitting and doing a, you know, big twisting movement, or even practicing turning your head side to side can help break through some of that rigidity. All right, so how can you get started at home? Of course, there's a disclaimer here that keep in mind these are general recommendations for exercise. They may not be right for you. If you have any concerns about your ability to perform these exercises, please consult with a physical therapist or your doctor. The Power Moves. I mentioned I was a Power Moves certified therapist. This stands for Parkinson's Wellness Recovery. It is a program based off sort of the godmother of physical therapy for Parkinson's disease, Becky Farley. She practices out of Tucson, Arizona. And so she has done extensive research and developed a series of exercises that really dives into the specific difficulties that people with Parkinson's have, but also adapted it to various positions. As you can see here, there's exercises lying face up or face down. There's exercises on your knees. There's exercises in a chair, and there's exercises standing. So it's really adaptable for any level. You can have a great workout just by sitting, you know, stay sitting in a chair the entire time. And so if you're curious about these, a lot of specific exercise classes for Parkinson's uses these moves. And I know the Parkinson's Association of the Rockies has some power-based classes. Sorry about that, little computer glitch. Okay, sit to stand. I mentioned this earlier. It's basically a squat, but the word squat sometimes sounds scary to people who don't exercise or aren't familiar with exercise, but sit to stand is something you have to do. You have to get up out of a chair sitting at your table. You have to get off the couch. You have to get off the toilet. You have to get out of the car. How many times a day do you have to perform this movement? So it's worth practicing. So you're going to start sitting in a chair. Firm chair is best to start in, so don't try this off the couch right away. Find a nice firm, you know, kitchen chair. You're going to stand all the way up and sit all the way back down. And again, lots of levels here. You can have, if that seat's a little too low for you to do this, boost yourself up, sit on a folded towel or pillow. If you need the armrest to help you up, go for it, but maybe you don't use them on the way down. Because that slow control down is also strengthening. If you plop back down, gravity did that work, not you. But if you control it on the way down, then you get extra strength than if you only work on the way up. Again, 10 times, because that 3 sets of 10 is good for strength training. Heel raises. So the ability to walk faster is a complaint I hear a lot as a physical therapist. And I won't bog you down with too much of the biomechanics of walking, but basically strengthening the calf muscle or the back of your lower leg is one of the key ways to increase gait speed or your walking speed. And so these heel raises help improve that. Your calf muscle is also really important for balance. So you can stand in front of a counter. Again, you can hold on if you need to, if you want to. You can, like I mentioned earlier, go just to maybe fingertips or one fingertip for an extra balance challenge. And you're gonna push up onto your toes, keeping the legs straight. So you're thinking about going up like an elevator, not propelling yourself up like a jump, just straight up and straight down. And again, 10 times, 3 sets, since this is a strength exercise. But this also can be a balance challenge if you let go or let go a little bit. So those are just a couple examples of some exercises, but again, we're looking at already some functional things. We're doing up and down out of a chair, strengthens pretty much every muscle in your legs. If you also don't use your hands to get up and down, it's a core and a balance exercise. For your calf raise or your heel raises, again, balance, depending on how much you hold on. It's a strength exercise, and like it directly correlates to walking speed. So one takeaway I hope everyone has from this whole series of presentations, this is the third of the series, is to create a team. That team is both a medical team, so a medical doctor, your neurologist, your physical therapist, maybe an occupational therapist, and maybe a speech therapist. So briefly, I'll do a quick plug for my other rehabilitation specialists, the OTs and the SLPs. Occupational therapists focus both on fine motor control. So if you have a strong tremor that's affecting your ability to perhaps button your shirt, to use a utensil to eat, they can help either with strategies or adaptive equipment to make that easier for you. They also work on activities of daily living. So that's, if you're having difficulty bathing, dressing, grooming, again, eating, those sorts of skills, that's what they specialize in. Speech language pathologists or speech therapists can help you if you feel like your voice has been affected. A lot of people get a quieter voice, have a hard time projecting if they have Parkinson's disease. They can help with that. Or if you notice that you're not swallowing food as easily and you're maybe coughing or choking a bit more. Again, like I said, Parkinson's disease affects motor control, and swallowing is a motor movement. There's lots of muscles involved in that, and that might require a speech therapist to help. The APTA, or the Association of Physical Therapists, has a Find a PT tool. And so if you go to that website, apta.org, there'll be a link, I think at the top of the page, but don't quote me on that, somewhere on the page for Find a PT. And in that tool, it allows you to, first of all, look in your area, but also look for a certain type of specialist. And so there may not be a neurologic specialist in your area. There aren't enough of us, if I may say that, but there definitely are some. Again, that's a clinical specialist, but also some people are not certified clinical specialists, but have spent many, many years working in neurologic care. And so use that tool to find someone who really knows neurologic physical therapy and therefore knows Parkinson's disease. It's a very specific disease process and requires specialized care. And so if you need specialized exercise recommendations, again, if you're falling, if you're not sure how to exercise or if it's safe for you, that's the time to go see a physical therapist. If you are comfortable with exercise, you're maybe very early in the disease process and you're still moving around really well, you might not need a physical therapist right now, but that tool is always there for you. I encourage patients to check in with me even if they're doing well. And that check-in is sort of like going to the dentist. You go for your check-ins, you make sure everything's okay, and that's from a trained eye looking at things. And then if there's a problem, then you might go in for a couple more visits, closely together as a tune-up. And so even when my patients, are doing fantastic, I still say, okay, I'll see you in 6 to 12 months. Maybe that's just one visit. Everything's still great. Amazing. I'll see you in another 6 to 12 months. But sometimes they come in and say, I noticed I've been having a little more difficulty with walking, with balancing. I can't quite get off the couch like I used to, or get out of bed like I used to. We might take 4 visits and really hone in on that skill that we need to improve. And then they're back on their own to exercise and work on that skill until they're either next check-in or the next problem comes up. Friends and family are a huge resource for patients with Parkinson's disease, because one of those secondary symptoms of Parkinson's is often anxiety and decreased motivation. And so if exercise is good for you, but you just can't find the motivation to get there, recruit a family or friend to help you. Say, can you go on walks with me? Can you exercise with me? And it just helps get you out the door and doing what's so important for you. Community resources, support groups, either group classes or just talking support groups can be so powerful as you live with this diagnosis. So I'm going to open it up to any questions.
Great. Thank you so much, Lyndsey. That's such an informative presentation. I hope everybody enjoyed that. Just as a reminder, there are 2 different ways to ask questions. So the first is to go to the chat box to the right on the control panel and type in your question. The second way is to raise your hand and we will be able to unmute you and you can ask your question live. So we'll give it a little bit of time. There were no questions during the presentation, so we'll give it a little bit of time and see what we've got here. So Lyndsey, I know that you talked about kind of how much exercise to do and the different levels. And I know a lot of people ask that question. There are so many different types of exercise for people with Parkinson's. Do you, when you meet with people, do you kind of direct them toward the best type of exercise for them?
I do, when it's greatly affected by their input, because it depends on what they have access to, especially in these times when either a previous gym or community center or group class isn't open yet, or they're just not comfortable going quite yet to a group setting, then maybe the exercise has to occur in the house. So we can figure out a plan that works. Maybe they have a stationary bike somewhere in their house, or they might be willing to get one, or a treadmill or a piece of equipment. So it really depends on what they have available, because there's not one best kind of exercise, especially for aerobics. So I'm very open and flexible to whatever they have available and whatever they're interested in. If they absolutely hate riding a bike, I'm not going to suggest it. So yeah, I definitely make recommendations, certainly, but it's heavily influenced by their input and interests.
Okay. And then I've heard too that the best kind of exercise is the exercise that you will actually do.
Yes, absolutely. I say that all the time.
Perfect. And still waiting, no questions yet. So let's see, I want to give it a little bit of time. Here we go.
And again, in the handouts are that RPE, or that scale, that 1 to 10 of how difficult you're working. That's in the handouts, as well as one-page summary of all those recommendations of exercise, you know, how many days to do strength training, how many days to do balance, how much aerobic exercise, all of that is in the handout as well.
Terrific. And I also in the handout is a list of our classes. So you can actually download, we offer 63 classes a week, all for free. Some are back in person, some are still virtual, but on that list, it will tell you whether they're virtual or back in person. And so we do have a question, Lyndsey. So any recommendations for people that have lower level mobility and are already chair bound?
Absolutely. So there are lots of recommendations online for general exercises. You know, the sit and be fit kind of classes are great. It's a little bit trickier sometimes to find ways to strengthen muscles, just because it's harder. You know, we have to find ways to adapt to that seated position, but it's certainly possible. A lot of times those elastic bands come in handy for those kinds of exercises. So in that case, I would start by looking online for some resources that way. There are also, you know, a physical therapist will have tons of recommendations for you as well if there's someone in your area that you can go see, but absolutely tons of things you can do.
Perfect. Okay. And let's see, we'll give it a little bit more time. So if anyone has questions, just go to your right and type it in. There's a hand raised, so bear with me a minute. Mm-hmm. Elena normally does this for me, so I am learning how to navigate this. Let's see. Let's see, I had the hand raised. Hold on a second. I saw who it was. So let's see. Margie, I saw your hand raised. I'm trying to get to you to unmute you. Hold on one second. There we go. Okay, Margie, I have unmuted you, so you just need to unmute yourself and you can ask your question. Let's see. All right, Margie, I'm going to give it a few more seconds here. Okay. Okay, so let's go to the next question. Margie, if you have a question, just raise your hand again and I'll be able to unmute you. So I enjoyed exercising on an elliptical, but the last few months have been tough. My quads have weakened and I struggle standing on it. Have you heard people having issues with that on ellipticals or treadmills?
Yes, definitely. And the elliptical requires some climbing to get onto and some balance, you know, to get your feet in the right position. So that certainly could present a challenge. And the same, a treadmill is tough. I mean, it's a great tool, especially in a controlled setting in a physical therapy clinic, when we can, you know, make sure it's safe and be there to, you know, help catch you if needed. But otherwise, it can be tricky on your own because the pace is set for you. And if your quads burn out a little bit and are weaker and you can't keep up that pace, it presents definitely a safety concern as well as just a challenge. So definitely common. I would say if it's available to you, a stationary bicycle could be a great option. It will also help strengthen your quadriceps so that you can maybe get back onto the elliptical or treadmill, but it will still give you that aerobic exercise and just be a bit more possible for you at this level. There also are seated ellipticals, and so they're portable, so you can even have one at home, sit in your favorite chair, and do an elliptical that way if you really like that movement.
Great. Okay. And then David has his hand raised. So David, I have unmuted you. You need to unmute yourself and you can ask a question.
I just have a question of, I'm not sure whether I was just diagnosed about a month ago, and I have a neurologist who I believe is very reputable, and I'm just trying to find out whether or not, I haven't asked her if she's a movement specialist, and I'm taking standard physical therapy right now, but you know, are there specialized physical therapy for Parkinson's? And or I just started playing ping pong this week, which is a sport I played decades ago. Does that sound like it's a good idea?
It sounds like fun. And so I would say if it feels safe, for you, ping pong is very dynamic, quick movement side to side, of course. And so if you feel very stable in doing so, absolutely, those quick movements, those large steps you have to take in reaching for the ball are fabulous for Parkinson's disease. In fact, I'm bummed I've never thought of that myself as a tool. I might have to get a ping pong table for my clinic. And so, yeah, as long as you feel safe to do so, your balance isn't quite affected to a large degree yet, then absolutely ping pong's wonderful. In terms of the neurologist, it probably would list on their website if they're a movement disorder specialist. You don't have to see one. Typically, movement disorder specialists are great for people who have difficulty with the typical medicine regimen that they recommend. They might dose things a little differently or have some different ideas on how to combine medicines if you're not tolerating the typical dosage. They also work with people who have what we call atypical Parkinson's or Parkinsonisms. And so those are related to Parkinson's disease, but with slightly different pathology and course of disease. So if you've just been diagnosed, you may or may not even be on medicine at this time. You're probably just great sticking with a neurologist, but know that option is there if any of those differences start to appear for you. And in terms of physical therapy, again, if you are early in disease process, not having too many specific difficulties in movement, then because general physical therapy will work on strength and flexibility and exercise in a more general way, it's great as a start. If and when you start to develop more specified movement difficulties, again, things like more balance challenge or more difficulty with initiation of movement or stopping movement. Those are things like I want to go and my feet just won't start moving, or I can't stop when I want to turn and my feet shuffle and I kind of get that called festination. When those start to present, I would recommend trying to find someone who specializes in Parkinson's.
Thank you.
Okay, thanks. All right, and then we have a question from Ronald. I'm taking Rocksteady Boxing that seems to incorporate all these suggestions. I attend twice a week. Is that enough?
Those are typically an hour-long class, if I'm not mistaken. And so, again, looking at if that's 120 minutes per week, and I know those are high-intensity classes, that's a great place to start. I would say maybe if you feel like there's one aspect that might be missing, and again, I unfortunately have not been able to attend one of those classes. They've not been either close enough to where I've lived, or of course in the last year and a half haven't been into a gym setting. And so so I'm not speaking specifically here from any specific experience, but if you feel like I wish they worked a little bit more on balance, or I wish I could strengthen my legs a little bit more, because boxing is certainly a lot of arm exercise, then you may add in 1 or 2 more days on your own to work on those. Or if there's a specific skill you feel you need to work on, for instance, getting on and off the floor, or again, walking quickly or balancing while you turn, things like that, then again, 1 or 2 more days a week to work on those skills would be great. But Rocksteady is a great program, and twice a week is a really good routine.
Okay, terrific. And then a question from Marilyn, and you've just answered the boxing question. So how about Tai Chi or yoga?
They are both great for strength and flexibility and balance. To my knowledge, there's not a lot of specific research on those 2 types of exercise for Parkinson's disease, but there has been research on Tai Chi and balance in general, especially with aging adults, that it can significantly reduce your risk for falls. So absolutely, they're great exercise forms. I will say, if that's all that's happening for exercise, it does seem to be missing that aerobic component. And so I would look to add in some form of aerobic exercise as well.
Okay, terrific. And so that is all of the questions that we have. Thank you so much, Lyndsey. I just want to let you know what the next portion of this presentation will be. We're going to take a very short break. right now. If you can be back in front of your laptop or iPad or however you're watching this, by 4:51, we're going to be hearing from two people who have Parkinson's and their recommendations and what they do currently for self-efficacy for themselves. So it's going to be a really good second half of this presentation. Lyndsey, thank you so much for your time, and we will be back here in about 4 minutes. Transition. So I want to announce Betsy, Mathies, and Hal Pottle, who have worked with PAR for a long time. Both of them have Parkinson's. I'm going to let them talk about themselves and their experience, but they're really going to talk to you about their experience with Parkinson's, kind of what they have learned, and share a little bit about self-efficacy. So Betsy and Hal, I will let you take it away. Thank you.
Wonderful.
Great. Well, hello, everybody. It's a little strange that you can see us and we can't see you. So hopefully I won't be too weird about this. But anyway, it's great to have everybody here. I was diagnosed with Parkinson's about 10 years ago. And it started off in probably a similar story to a lot of you. It took about 1.5 years to figure out what was going on with me. It started off with my gait, and just literally felt like one morning I was walking with this unbelievable kind of drop foot thing, and it was wasn't painful, but very noticeable and very uncomfortable. And so went through a litany of tests and doctors, and was originally diagnosed with something called runner's dystonia. And it actually got so bad that I could walk backwards normally, I could run forwards normally, but my toes were curled up so much I couldn't walk forward. And so I think my lowest point was when I was walking my dog around my neighborhood, and hit a point about halfway between where I was and home, and I couldn't, my crazy toes were so curled up that I had to walk backwards. I had to walk my dog backwards for about 1/2 mile. And then I thought, oh man, what in the heck's the matter with me? Well, so anyway, I got again kind of a litany of tests, and again a DAT scan, and which kind of solidified that I had Parkinson's. It had, all my symptoms had been going on so long that probably, like a lot of you, it was ultimately a relief to figure out what was the matter. And I cried buckets when my doctor told me that it was Parkinson's, and I really haven't cried since then. So anyway, that's my story. I'm 63 now, and still able to do most everything that I could 10 years ago. Hal?
Betsy, it's always, she is such a dear friend of mine. When I first took the self-efficacy class, Betsy was one of our coaches who helped us to then subsequently be leaders of a class, and so it was a real honor to get to know her in that capacity. My story, everyone on this call has had the situation of being sitting in the doctor's office, and possibly like my own expectation was that he'd come out and say, go to a chiropractor, get your back cracked, you'll be fine. And that's really was the only thing I was expecting, and I was just completely flummoxed when he came in and said, you've got Parkinson's, here's a brochure, I'm going to give you some medication to get started, and we'll see you again in 6 weeks, and kind of go down the road. And walked out of the office just in a fog. Just had I couldn't really even process the information. And I was so petrified that it took me 10 days to actually tell my wife. I processed it in solitude for 10 days and wouldn't recommend that, honestly. It was not a pleasant 10 days, but fortunately a good friend of mine just told me that it's time. He's like, you need to tell her or you're going to offend your wife. So what we wanted to talk to you about today, we're going to discuss self-efficacy primarily because it's had such a significant impact on our lives, but we're also going just to share some of the experience that we've gained along the way, and hopefully, some shortcuts for you or some notes for you for some things that you might want to look into. So without further ado, we'll move forward. We call the presentation "No Silver Bullet," just because we haven't figured it out yet. We're still struggling along with the rest of you, putting one foot in front of another, but we have learned a few things along the way. So one of the things that we know about Parkinson's is that it is very, very complex. And if that's not something that you've encountered with Parkinson's yet, it may be on the horizon. It is considered a movement disorder, obviously, because that is the things that sends most of us to the doctor for a diagnosis, but has some very interesting characteristics in that for many people, actually the non-motor symptoms are more significant in the expression of Parkinson's that they share. And unfortunately, the non-motor symptoms that are most common are depression, apathy, and fatigue. And those three together make a very strong cocktail, and not one that anyone really wants to be trying. But it is different from many, many other diseases because of the complexity of it and the unique expression that most everyone will have a unique set of symptoms that they will be challenged with. And in that, it makes it quite challenging to visit with doctors and to get an opinion on such a broad range of symptoms that we are challenged with at one time. So one of the other things that we've learned regarding self-efficacy is a construct. It was first discovered and named this by a psychologist from Stanford named Albert Bandura. And Bandura worked during the 20th century, was a very prolific psychologist and wrote quite a number of papers and books on the topic. But one of the concepts that he had was that for you to deal with something, you have to own it. You have to own the responsibility of it. And Betsy and I have both found that to be very true, that we have to own our life with Parkinson's and take full responsibility for it. So one of the quotes of Bandura's that I particularly am attracted to and has meant a lot to me, and this is I think gets to the part of the real core of his message, is people who regard themselves. So it's not the way other people see us, it's the way we see ourselves. People who regard themselves as highly efficacious, they act, think, and feel differently from those who perceive themselves as inefficacious. They produce their own future rather than simply foretell it. And we're going to talk more about that towards the latter part of the time we have together today. but we wanted to at least introduce the concept, and we'll talk more about it in a few minutes. One of the first things, and you just had a marvelous presentation on exercise, but one of the first things that Betsy and I have found, and I don't think I've ever talked to anyone who has Parkinson's who hasn't found that exercise is probably one of the greatest gifts that we've been given, to feel better, to see our symptoms lighten, and by finding the right mix for us, we can address a number of the symptoms that we have and live a much higher quality of life. And obviously you just had a marvelous presentation on that, so hopefully you're quite inspired on that. Betsy.
Okay, so another key part of handling your Parkinson's is obviously medications, and just like everything about Parkinson's, it's a complicated process, and finding the right cocktail for you, and that is, a difficult job for your movement disorder specialist unless you keep good track of your symptoms, you keep a good journal. That helps them kind of figure out. There's many different medications that can be used by themselves in conjunction with others. I'm not going to talk about those in particular right now, but just to say that once your doctor does prescribe medications to you, number one, keep a good pill box, keep track of them, keep a list of what meds you're on your person or somewhere at all times. And the biggest, I think, question for people is why, like Hal's on a different cocktail than I am, and then probably all of you in the audience are on a different cocktail. It just depends on what your symptoms are. One other thing that I want to address is that there's this kind of carbidopa, levodopa fear of getting started on that medication right away. And I'm here to kind of help dispel that. That is the gold standard for Parkinson's. It's been around since the 60s, and it's a great medication. It's now being produced in a multitude of deliveries, either on your tongue. There's some inhalers, obviously oral. There's long-acting, extended release. There's a lot of different ways to take it coming down the pike. One of the boo-boos that I made, and so make sure you understand what you're doing when you leave your doctor's office. One of the boo-boos that I made is that when I was originally prescribed it, my doctor told me to take it 3 times a day. And so I'm thinking like taking an antibiotic. So I'm taking it at like 8 in the morning, noon, and then maybe 8 at night. Well, when I went back for my second appointment and I told him when I was taking these meds, he said, "What are you doing that for? Why are you taking it at 8 o'clock at night? And then you go to bed in an hour." You want to maximize the time you take it during the day so that while you're up and going, your medicine is working for you. So anyway, don't look at what everybody else is taking. Just focus on yourself. Take good notes on off and on times if you can feel when you need to take your medicine, if your symptoms are starting to show again. It's one of the very key things that you should stay in real good contact with your physician about. And again, there's a lot to that. I'm not going to address all of that now, but just know meds are now a key part of your life.
Absolutely. And one of the things that I wanted to make sure and and share was just the effects of hydration on Parkinson's. You may or may not be aware that 60% of the body's weight is water, and that moves up to 73% when you're talking about the brain and the heart, so a very high percentage. With Parkinson's, there is the lymphatic system, which pulls toxins and dead cells, things out of our bodies. The lymphatic system is actually slowed down. Many of us will struggle with constipation, for instance, and there's just a whole variety of issues that hydration can be a key in being a part of the solutions. I'm not saying it's everything, but it can certainly be key. And there's a whole variety of different approaches as far as how much water you need, but find what's right for you. For me, it was significantly more than what I was drinking. I drink probably right in the vicinity of about 90 ounces a day at this point, and it's just that works for me. And yes, it does involve a number of trips to the restroom, and the issues with that sometimes when you're trying to play games at home or something can be a bit taxing, but otherwise it's really a very important component of your managing your Parkinson's. Betsy.
Okay, so developing your own healthcare team. I'm going to address really developing your best relationship with your physician. A lot of the healthcare team kind of will come down the pike. So I've thought about it, and I think I'm just going to focus right now on how to have the best relationship with your neurologist. First of all, Hal and I would both say emphatically, if you are not already, you should see a movement disorder neurologist, not just a regular neurologist. Maybe they're the ones that have helped, get your diagnosis. But from this point forward, you really should be seeing a movement disorder specialist. They have had more schooling. They are on top of the latest medications, DBS, other kind of treatment. A regular neurologist is wonderful, but they know a lot about a lot of things. And as we alluded to, Parkinson's is such a complicated disease. You really should see somebody that is zeroed in on that. So that said, the other kind of ironic thing is that here you have this complicated disease. You end up seeing your doctor usually twice a year. And for about 20 minutes, maybe 25 minutes. So it's a lot depends on you then, you being an advocate for yourself. So in that time when you don't see your doctor, this is when it's important to, keep track of your health. If you see patterns in maybe feeling dizzy, or if you see patterns that with your sleep or depression, like some of the non-motor things that Hal alluded to, write them down. If you find that a certain medication is causing you side effects that are worse than, if they're helping you, you need to write it down, and notes to help you remember. Bring somebody with you, also very important. A lot of times your care partner, as we call them, can share things and knows things about you that you don't know about yourself. So always good. And to hear what the doctor has to say. Sometimes you can get stuck on one thing that he said, and he's moved on to, or she moved on to another topic, and you've missed it. So important to bring somebody with you to an appointment, and you should ask questions. They want you to question, what it's your health. And so be proactive, read up on things that, articles that maybe you want to discuss, and just basically be prepared. Be on time. Don't be, if you're late, if you're 10, 15 minutes late, then there's most of your appointment wasted. So they're usually very smart, very thorough physicians, and they're counting on you to be a big partner in helping keep you at the best you can be. So I guess to summarize, I would just say good record keeping on your part on everything. Just, how your medications are making you feel, how you feel they're working, that kind of thing. If any other symptoms are popping up, you just need to be proactive about remembering those things. Bring somebody with you to the appointment so you have another set of ears. And was there something else that I forgot, Hal?
No, actually, I think you covered it really well, Betsy. There's so many things you could go into when you're talking about your interactions with your healthcare team. But I think you hit a lot of the real key points.
Okay, thanks.
One of my personal passions is for clinical trials. I got involved in clinical trials a few weeks after I was diagnosed, and I heard about a clinical trial and thought that I wouldn't be able to participate. And I went ahead and called and sent an email to the coordinator, the research coordinator on the research that I was interested in. And she called me and she said, well, the medication you're taking, it only takes a few weeks to clear from your system. And then, you would qualify for the trial. And so I did my first clinical trial. It was a medication trial. And we were doing what's called phase 1, which was the basic safety trial. And so it was only a 6-week trial, but we did that. And when I was finished with it, there were all kinds of other trials that were listed. And so I was like, well, let's do one of the other ones. And when I met with my movement disorder specialist, and I told him, I said I was in my second clinical trial at that time. And I said, I would really like to just use exercise as my medication for a while, as long as I'm doing well, and participate in these clinical trials, because it seems like almost all of them are looking for newly diagnosed patients who are not on medication. And that, as I have found, continues to be the case, because there's less factors for them to have to consider. So the less factors they have to consider, the easier it is to be able to filter through what the true results of the trial are, what they're actually getting from it. So for 2.5 years, I did not take any medications that were not part of a clinical trial. And I'm actually in my 17th clinical trial at the moment. I am doing a clinical trial for a subcutaneous form of levodopa-carbidopa. It is unbelievably effective. It has taken out my issues with off times almost completely. It is remarkable. It should be on the market within the next 3 years if there are people willing to participate in the clinical trials so that it can get approved and it can get out onto the market. There are, unfortunately, every year, there are trials that shut down completely because of volunteers. So it's something that is just so sad, because even I've been in trials with medications that I've done extraordinarily well with that ended up failing So the trial did not go through as successful, but they learned a tremendous amount from that. And other researchers now are using the information from that failed trial to develop new therapies, because it's nothing's wasted. It doesn't matter if the trial is successful or not. That information is gleaned and people build on it, and that's where we get these breakthrough drugs that are coming hopefully down the pipe very soon. So my last comments on this, and I tell people this, and with all humility, there are wonderful things coming. We've got a fabulous research grouping out there of physicians and specialists and chemists and physicists all over the world studying to make Parkinson's, something of the past. But nothing is going to change that doesn't come down the road of clinical trials. That's the only possible way it's going to come. So I would encourage each of you to consider it. Michael J. Fox has a site. If you go to his main site, you'll see Michael J. Fox's Trial Finder. And that's a marvelous way just to see if there's anything locally available for you that you can get involved with. And if you have any questions about it, please feel free to ask us at the end. Betsy.
Yes, PD buddies. Let's see. So PD buddies are a wonderful thing that you can attain through the PD Self program. The wonderful thing about PD Self is that it's geared for people that have been diagnosed with Parkinson's 3 years or less. So you're all in the same category pretty much, and usually having the same sort of symptoms, degrees of symptoms, that kind of thing. And it's for a lot of people, when you're first diagnosed, you don't know anybody that has Parkinson's unless, your great aunt somebody or your great uncle somebody had Parkinson's. A lot of times you're meeting people for the first time that are your age, that are, going through this. And that becomes just so wonderful and important as the time goes on, getting to know each other. It's just invaluable getting to share that. Even your best friends and your loved ones, they want you to share with them, but they want to desperately know how you're feeling, but there just isn't a way that you can explain it except to somebody that's going through it with you. And so you'll find yourself ending up with
Bets, did you drop off there?
Yeah, Betsy, we can't hear you. We've lost your microphone.
Well, I'll go.
Okay,
Betsy,
go ahead, Hal. Yeah, because she's just doing a fabulous job right now.
she is indeed. And
Yeah.
I just
and
Oh,
so
oh, she's back?
Betsy, can you hear me okay? You dropped off there for a little bit, and I know that you were just pouring your heart out. We lost you. I know we lost you.
I was just talking about such interesting things.
I know you were. We lost you kind of after getting together with that buddy and what you can do with them. So if you want to back up a little bit, that would be great.
Okay, you bet. So I was just going to say that one of the wonderful things about PD Self and getting to know people with Parkinson's at the same stage that you have is that your friendships just solidify and are deep right from the get-go, because you get right into the weeds with them right from the start. There's no small talk. You're talking about bodily function issues or very deep emotional issues, and so there's just you'll end up having this whole other part of your life that you become very close to, dependent on, and is actually kind of a, what do I want to say? It's an addition. I mean, we're lucky that we can end up meeting people we would have never normally met sometimes, and can you get great comfort in knowing you're not alone going through Parkinson's with somebody else. So your PD buddies are usually, you know, who you've met either in your PD self class or through boxing or all the other exercise programs that can be geared for Parkinson's. And you'll find when you go to these symposiums and things like PAR has, it's like old home week, and it's so wonderful to see people and see how they're doing. The PD buddy is also very key, I think, in exercise, especially if you aren't one of those that you're, you know, pop out of bed every morning and you just can't wait to get on that treadmill, or you just can't wait to get out there and run. Sometimes if you know you're going to meet somebody and they're counting on you too, it kind of forces your hand a little bit. You can encourage each other to push yourselves more. So Parkinson's can be isolating, and meeting people, opening yourself up to people that you'll run across through these different venues is so important. I really encourage everybody to get involved in some sort of support group, a PD self program, an exercise class. Do it and share yourself with others. It's invaluable.
Thank you so much. The only comment I would add to that is there are some support groups, and I'm not picking on anybody, but there are some support groups that you might visit where people are complaining about their disease and they're not taking action. Please leave and don't ever go back. Find a group of people who dynamically are changing their lives, are taking control of their disease, and who have bright, shiny faces, and you're delighted to see them because they draw you up when you're down. There comes a time where we need it, and it's just invaluable.
Great point.
Education. It is a complex disease, as we've said. There are tremendous resources out there, and I don't want you to overload and feel like you've got to read everything, but what you will find, what we found certainly, is that if you are very aware of the particular symptoms you have and you read up on them and you form your questions when you go to your doctor, that you've got those prepared, you've got your top 3 questions that you want to ask in that session, that it will really help you move forward in a very self-efficacious manner, I would say. So there's tremendous resources. Michael J. Fox has a third Thursday broadcast that is wonderful on a number of topics, and you can go back on specific topics and look at those. But there, Davis Finney out of Boulder has a marvelous book that if you haven't seen it, please request it. Go to the Davis Finney Foundation. He has what most of us refer to as the Bible, because it's so comprehensive. Has a marvelous book that they do every year. They update it, and it is just outstanding. And it's a wonderful resource when something happens and you're wondering, is that Parkinson's or not? It gives you that ability to go and read about it and get some additional information. But it is invaluable to have that, and the way that the control that it gives you in being in the driver's seat and being someone who owns their disease. The thing that Betsy and I really wanted to share from our hearts, and we were both, well, Betsy, why don't you tell about, because you were in the first class, why don't you tell about, getting in Diane's first class when she wrote the self-efficacy program?
So self-efficacy was first, it was developed by a woman named Diane Cook, and I don't know if some of you know her or have heard of her. She's one of the best things that's happened to people with Parkinson's, because she's an unbelievable advocate. She has Parkinson's herself, and she is a warrior for all of us. Anyway, it was developed with her physician, Dr. Rajiv Kumar, and she had seen a talk by a woman named Margaret Shankman on exercise and the importance of exercise with Parkinson's. She was diagnosed just shortly before that. She was also very aware of the concept of self-efficacy, as Hal alluded, developed by Albert Bandura, and that basically you have the power to help shape the course of your life, even though you feel like, if a big rock has come in the road. With the right thought processes of self-efficacy, feeling like you do have the strength and the power to go around that rock somehow, some way within yourself, you can pull that power and strength out. She then went to Dr. Kumar and said, I think that we could put self-efficacy and Parkinson's and exercise all together and create this program for people to change the way they think about their disease. And I would like your help. I'd like to run it as a clinical trial. So they got a grant from an organization and they put it together. They designed it together. So long story short, I was part of the first program, which was a clinical trial. And it was proven because they were able to what's the word I'm looking for? They could test the results that, in fact, people that had participated in the program were more apt to be involved in their communities, even though some of their symptoms still progressed. They were happier, more engaged in their community. So it was successful. So that was I think 2012 or 13. It's been around 7 or 8 years. So then the next year, I was a facilitator, and that was the year that Hal joined. And so it is grown now so that it's taught in 13 cities across the United States, and it's made up of the teaching team, or the facilitators, are somebody with Parkinson's and somebody that's well versed in the medical world of Parkinson's. A lot of times there's nurse practitioners, physical therapists, that kind of thing that specialize with Parkinson's. And it is geared for, again, I said, people that have been diagnosed within 3 years, as well as their care partners if they're able to come. And so it has become very well known, very sought out, very successful here in Denver. And the last couple or 2 or 3 sessions, they've done it virtually due to COVID. So that was quite an ordeal, rewriting the program to be delivered virtually and that kind of thing. But it's life-changing. It really is. And so anyway, again, been around 7 or 8 years. Hal, what would you like to add to what I've said?
Well, I was in the second class actually. There were only 2 classes that Diane Cook actually taught herself, and Betsy and I both became facilitators and facilitated back and forth together here in Denver for a number of years. And I have a class on Friday, as a matter of fact. The program, as a virtual program, is a 8-session program for 2 hours. It meets every other week on a day that's selected by the person who's facilitating or the team facilitating. And it goes through, and what it's trying to do is to help you understand self-efficacy and how it fits in your life, and how this construct developed by Albert Bandura back in the 20th century has been so impactful for people with chronic disease. These classes are taught, for other types of chronic disease, but Diane has developed the program, and it has done remarkable things for those of us with Parkinson's. We're going to try to talk through a little bit about what self-efficacy theory means, and it has so much to do with, and you see the way I've highlighted this, our beliefs about what we can accomplish influence our success in changing behavior patterns. Well, many of us feel stuck, and especially with Parkinson's, it seems like it is interminable, and we can't have any effect over it. But Bandura has proven, and clinical trials have proven, and numerous years of experience have proven that yes, indeed, we can affect the course of our disease. And they're one of the largest studies that's ever been done on self-efficacy found a very, very interesting result. And this is going back to a study that was done and presented at the World Parkinson's Conference in 2010. And at that particular juncture, this was one of the keynote addresses, and Diane Cook happened to be sitting in the audience. And the presentation was on self-efficacy. And of course, she turned to the person next to her and she said, "Have you ever heard of self-efficacy?" Because she hadn't, and she had not heard of that term. And what she was so impacted by was the charts and the descriptions of this very large study that had been done, that they found that the single largest indicator of the quality of life for the people who had Parkinson's was self-efficacy. It wasn't medication. It wasn't the progression of the disease. It wasn't whether they were, what their demographics looked like. It was their belief in themselves. It was their self-efficacy that impacted their life, even many times as their disease progressed. So it has an impact on the level of effort we will put into new behaviors. So it's so easy sometimes to lose faith in ourselves, but self-efficacy teaches us that if we continue to affect what they call measure of control, what are the things that you can impact? And when you take control of those things and you begin to exercise control over them, it changes your belief structure. It changes the paradigm and your perspective. We've all seen, the drawing of the old woman, the young woman, and depending on your perspective, you either see a lovely young woman or you see someone who's, you know, kind of an old hag in the same drawing. Well, this disease and our way of viewing that disease, the way that we view ourselves impacting our disease, changes that perspective dramatically, therefore changes the quality of life, because we no longer feel like we're just taken down the stream and have no control, and we're, you know, flailing. We realize that we do have control, and we learn how to exercise. So one of the other aspects is the tenacity to persevere. If you haven't proven to yourself that you have some of these control, it's very difficult to stick with it. And that's where people, when fear, excuse me, when depression, apathy, and fatigue show up in force, they're a formidable opponent. And if you've proven to yourself through setting goals, accomplishing them, that you can have impact on your disease, that gives you the confidence to continue to move forward. And so we see, they've seen in trials that there's a tremendous difference in the tenacity and resilience in adverse situations of those who have a high level of self-efficacy. And the challenges we will take on bigger challenges because we've proven our abilities with smaller challenges. And the quote, that this is once again another near and dear one for me, is people who believe. So this is where we prove it to ourselves, but we believe that we have the power to exercise some measure of control. And if you think about it, and you think about how that applies to your life, because sometimes symptoms, they seem that they own us. It can seem like that our tremor, that it just owns us, that we have no response to it whatsoever. It can seem like, you know, a wide variety of symptoms are just in control and we're not. But when we begin to find the areas that we can impact, and we begin to take on that measure of control and influence it, it changes our lives, changes our perspective. And so we're more effective and more successful than those who lack their ability to change their lives. We're going to try something new. We're going to try something we haven't done before. And this is our fifth time doing this particular presentation, because we want this to be real to you. We want you to go home with not knowing everything about self-efficacy, but having enough of an understanding that you want to learn more. You want to find out more about how this works and how it can impact your life. So one of the things that I've found, and I know Betsy has found, is self-efficacy is about getting better. It's about feeling better. It's about taking control and having a different perspective. So we're going to do something, and we're going to do some polls. So when you think about what we've said about self-efficacy, and you think about the way that self-efficacy might work, we're going to go through some scenarios, and we want you, there's going to be a poll. So we're going to bring up a particular scenario. We're going to talk about what possibly could be done, and then you're going to select an answer that you think sounds like the most self-efficacious way that you would want to respond to that particular scenario. So Betsy, I'm going to let you kick off with the first scenario.
Okay.
And there'll be a poll coming out here in just a bit after she explains this.
Well, obviously, Hal, this is a test for how well we got the point across. But I think hopefully you've got, in the last 45 minutes, you've gotten a sense, as Hal has said to the theory and concept of self-efficacy and how to apply it in this particular case to our disease and how to live with it. So here's this scenario. Running has been a consistent part of your exercise regime, but you've recently lost interest. Which solution best represents self-efficacy? So I'm not sure what you're seeing on, here we go. So the first one, as a friend or a spouse, or ask a friend or a spouse to run with you. 2, take a month off and throw yourself a big pity party. 3, research other exercise options that help slow the progression. I'm going to read, that had to be cut off a little bit. Let me read it again. Research other options of exercise that can give you the benefits necessary to help slow the progression of your disease. And the last one is buy yourself new shoes, running shorts, and a water bottle, then sign up for a 5K. So mark which one you think would be, if you were using self-efficacy, what would be the best approach of the 4?
All right. The votes are coming in. I'm going to give it a couple more seconds here.
Okay.
Okay, so let's see. Before I could share the response, and now I'm not seeing that.
Well, that could be a bit of a challenge for this aspect of
I can see the responses. Before I could share it on the screen, and now I'm not sure if I can do that. So bear with me here.
No worries.
Okay, I think when I close the poll, it's going to give me the ability to share the responses. So we have about 65% that have voted. So I'm going to go ahead.
Everybody needs to vote. Everybody needs to take a stab at it.
All right, I'm going to give it a couple more seconds here. Okay. So I'm going to close the poll in 5 seconds.
The polls are closing.
Polls are closing. Okay, so we're going to close this poll. And let's see, I can share. Here we go. So here are the answers. So we had a tie there for a little bit, but option number C pulled ahead at the last second.
Great. That's the one that I think best represents self-efficacy. Good job, everybody.
Excellent job. And you're going to see in these scenarios that you're going to have several options that are good things. So it's not asking a friend or spouse to run with you is a bad thing.
Right.
What self-efficacy will ask is, what if it's raining? What if it's cold outside? What if you hurt your knee? What's your plan B? And how are you going to deal with the obstacles that you run into? Because setting a goal is setting something that's out there that you impact by doing things today. So it's something that you want in your life out there, but you can impact it today.
Mm-hmm.
So self-efficacy takes it to that next step of saying, let's plan for these obstacles. Let's make this part of our plan because this is our life and this is what we want. Okay. So everybody who, let's do this. Everybody who got that one right, we can't see you. So if you, but everyone that got that answer, let's stand up, okay? And so we'll see who's standing at the end here. I was standing already, so, and I wrote the poll, so. All right, our second scenario is your balance is becoming increasingly worse. What action will you take? There we go. Okay, let's see the poll. The answers are, I will buy a new iPhone and Apple Watch so that it calls out for help if I fall. I will research balance issues in PD, ask for references for a physical therapist who specializes in PD, get evaluated, and develop a game plan with SMART goals. I will find a PD class that helps with balance. That's the third response. And the fourth, I will join Jeff Bezos on his trip to space where there is no gravity. Balance issue solved. Okay, can we see the poll for number 2?
Okay, we're going to give it a little bit of time to let people vote. So let's give it another 10 seconds here. Okay, so we're closing in 5, 4, 3, 2, 1. All right, here we go. We've got a tie again.
Oh,
Let's see. Let me share the poll results. Here we go.
oh, an absolute tie.
Wow.
Yep.
And so why would you think, so once again, finding a PD class that helps with balance, an excellent, excellent thing to do. I would highly recommend it. But what self-efficacy is trying to teach us is to take more of an ownership of the process. So if you take the class and you stop there, if the class isn't meeting all your needs, then what else are you going to do? And sometimes it's easy with Parkinson's to say, well, the doctor is going to prescribe the medication and that's all I need to do is just take my medication. Oh, I need to go to exercise. Okay, check mark, I went to exercise. Oh, I need to do this. And it becomes a series of check marks. And what self-efficacy said is, this is your disease, you're in control of it. So what do you want to impact? How do you want to learn? How do you want to choose the life that you want moving forward? And so it asks more questions and encourages us to have a better plan. Okay.
Excuse me.
Bless you.
All right.
There we go.
Here we go. Scenario number 3. Okay. Always known as a high energy person, fatigue is zapping me and I can't get anything done. What could I do? Okay. Number 1, dust off Jane Fonda videos to recapture old vim and vigor. 2, research fatigue and other symptoms. Discuss with whole team. 3, create napping area and try to keep naps short and effective. 4, get full body testing so you have all the facts to work with. All right.
Okay.
Let's see what everybody does.
All right. We're going to give it about 30 more seconds. People are voting. They're off and running. Okay, we'll give it about 10 more seconds. Okay. 5 more seconds. And here we go. So here are the results. Share. Okay.
Perfect. Well, that was pretty unanimous, wasn't it?
Yeah.
Yeah. I think they're figuring out whenever you see the word research, that kind of is your clue. But yeah, great job, everybody.
Well, and it's not that the other things are bad. In fact, very possibly they will be part of the solution.
Right.
Understanding that it's a part of the solution and taking into consideration the other factors instills in you that confidence that you are prepared and ready, because this is a chronic and progressive disease. So if you're anticipating what things might come through educating yourself and understanding what might happen, then you're better prepared for those things as they show up.
Right.
All right. And the fourth, sleep has never been a problem until your diagnosis. Sleepless nights are making you miserable. You feel like you're losing your mind. Which approach is the most self-efficacious? And the answers are: try a different over-the-counter sleep aid every week until you get some results. The second option is offer to babysit your toddler grandchildren. I'm assuming, I don't have grandchildren yet, that would be a very tiring exercise.
Trust
Develop
me.
an ordered and consistent sleep hygiene program, keeping a sleep journal, looking for any patterns that emerge. Discuss with your movement disorder specialist at your next appointment. And the last, which probably would work quite well as well, reread War and Peace.
Okay, we've got about 20 more seconds left for voting. This one is a runaway. There's no questions here. So let's see. So we're going to go 5 more seconds.
Okay.
Okay, and we're going to close the poll. And let me share here. Okay.
Well,
There you go.
and so there, now you don't have to attend the program. You just, you're already at scoring 100%. Far, far, far from it. But it's the program is something that Betsy and I have seen completely change our lives and change the trajectory of our disease. And it's something we would strongly encourage you to at least look into. There is a fall program that will start, like I'm thinking in the August timeframe. I don't have the most recent information on that, and we can certainly get that to you through Jody and get you the website and the information specific to the program. But it is it's been a game changer for us. My last slide, unfortunately, because as I said, this was experimental that we did the scenarios. My last slide with the question mark was questions, but unfortunately, I overwrote the questions with our scenarios. So at this time, could we open up the mics and address any questions that anyone has?
Okay, and we do have quite a few questions that have come in that I have now I'm trying to find them again. Hold on one second.
Well, Betsy would be happy to answer those questions.
I need to make them a little bigger, and some of these I have a feeling you're going to refer them back to your doctor, but we will start with them.
All right, hit us up.
So the first question we have is, with Cinemet, how careful do we need to be with taking protein? What length of time should there be between eating protein in a meal and taking Cinemet? I think we get this question every time.
Betsy, you
go. You go.
Okay. Cinemet is, it does have, and it varies with different people. It does have some impact based on protein. For some people, they're very, very sensitive to it. For others, they have a very low sensitivity, and so they'll have, a big thing of yogurt and berries in the morning, and it won't impact. They'll take their Cinemet and it won't impact it whatsoever. Others, it does have quite a bit of difference. It does create for you, and I have looked at this. It can create a kind of a crazy life when you're trying to. What they recommend is 30 minutes before or 2 hours after. Well, if you kind of lay that out, and depending on what your frequency is of dosing, it can be really challenging to either get 30 minutes before or 2 hours after meal to take your medication. One of the things that I will encourage you with is that the clinical trial that I'm in, because it is subcutaneous, so it actually comes in through your skin on your tummy, that bypasses those processes. And so I had a great big and had absolutely no impact whatsoever on my the effect of the medication. So there are ways around it that are coming down the pike. So you'll be glad to know.
And it's carbidopa levodopa. Cinnamon
Yeah.
is levodopa.
Hey, this question is specifically to Betsy, I think because of your reference earlier about medication. So what is your carbidopa levodopa timing schedule? I was also told 3 times a day by my MD, I tend to crash mid-afternoon on a 7 through 11 p.m. schedule.
I'm sorry, repeat the last part, Jody.
Yes, so what she's saying is that her schedule right now is to take her medication at 7 a.m., it looks like 3 p.m. and 11 p.m., and she tends to crash mid-afternoon.
Yeah, so that's a question for your physician, because maybe you need to add another dose in there somewhere, or a half dose or something. But and again, the dosing is probably up to your physician as well, but it's to maximize, take it so that you're, if you get up at 6 in the morning, take it at 6. I mean, if you get up at 7, take it at 7. It's then to maximize the time that you're up and going about your day to help you with, with your movements and all of that kind of stuff. So I go to bed early. I get up early and I go to bed early. So that's why I'm taking it 6, 12, and 6. I don't know if that makes sense, but exactly what I said in terms of writing down things to discuss with your physician. That's a good one. Write it down. Be specific. How long have you noticed that it hasn't been holding you until your next dose? Is it every day? Can you see a pattern? Is it if you've, just not had a good night's sleep the night before? All of those things you may think don't seem pertinent, but they are. And so, yeah, if you need to, that's something that they need to help tweak.
And I will add to that, there's also a lot of new medications out there that are short-term and quick acting. So when you do have a crash or a downtime, they're very quick acting. So that's also something to talk to with your doctor, because they might prescribe something to supplement your usual medication.
Yeah.
So I think I have a hand raised, David. I'm going to try this. I'm not sure if this is from the old one or if this is a new hand raise. So you are unmuted. So David, if you have a question for Betsy and Hal, you can unmute and ask that. I'll give you a couple seconds. Okay. I think that was from the first session. So,
Okay.
Okay, so David, if you did have something, just you could put it in the chat box. So we have another question here. What exercise are you doing, and what do you recommend?
Hal, you start.
That's a very complicated discussion, and there are what I have found personally, and I share this with people, not out of trying to say, do it my way, but what I found personally was that as I slowly up my intensity of exercise, that I found myself in spin classes and I found myself in HIIT classes, that the intensity of that I was able to do and I am able to do, and that the more I upped my intensity of exercise, the less my symptoms showed. And I was actually doing a class, and I pulled up the symptom list that I take with my, when I go to the doctor, so I can discuss the things that are important to me. And I looked at it, because it had been 6 months since I'd looked at it, and I looked at it and I thought, none of these things really are bothering me right now. And it was amazing to see how my symptoms went to the background as I upped my intensity. But I do yoga, HIIT classes, spin classes, strength building, work with a trainer, do as much as I can do, but it started a little bit at a time. I was a walker. I just walked, at lunch. That was, and so all this has happened in the interim period since then, a little bit at a time. As I felt successful, I kept moving forward.
So I do a Peloton. We got a Peloton, love it. So I work out on a Peloton 4 days a week. I swim in the summer, probably 3 days a week or so, maybe 4. Walking, nothing better than walking, but you got to walk at a brisk pace. This isn't, I mean, anything that you do that gets you moving, and it should be at least 30 minutes, but you should be walking, and maybe this was addressed with the person before us, so if I'm repeating, I'm sorry. But if Hal and I are walking, we should be walking at the speed that we're not totally out of breath, but we're pushing ourselves so that we're a little breathy. So, and yoga. So I get a little bored and I mix it up. You just got to do something and, mix it up, do it with different people. Seasonally, things can change. So that's my pitch.
And I will go back to the best exercise is one you're going to do.
Yes.
So if you hate to ride a bike, don't start riding a bike because you're not
Right.
going to do that. And then the other thing I would say is for those people who may have major balance issues or may not be able to get up and do a brisk walk or anything like that, there is chair yoga, there is chair aerobics. So there are things that you can do even sitting down that's going to get your heart rate up and get you moving. That's better than doing nothing. So.
Right.
And then our last question is from Suzanne. So I'm happy to see you were able to get logged in because she was having issues earlier. How do we sign up for PD Self?
We will, the website, is it Betsy, you're on the board and I'm doing this, it's pdself.org, I believe. So it's
Self.org.
And if you go to the site, I don't believe they are open for enrollment for the fall program yet, but there will be. We're still planning at this particular juncture for that to be virtual. And virtual has been, I'm doing my first team through the virtual. It's challenging. It is, I think post-COVID, also so tired of not having real connection, but we're finding our way through it, and we're pulling some value, and we're actually finding people really drawing together in a surprising way. I think the class is really unique. So I would encourage you, don't wait for the live class. Try to get in the virtual class this next term if you can.
Okay, perfect. And then we do always get notification of when classes are happening for PD Self at the office. So we do have it on our community page on the website, but you can always call the office and we can get you connected to the right people to help you get signed up for that. We think it's an amazing class, so we fully support that and always disseminate the information. And so with that, we are a little behind schedule, but we wrapped up pretty close to time. So I really do appreciate everybody's time tonight. Betsy, Hal, thank you so much. That was a fantastic presentation. I think it really helps hearing your perspective of people who have been through it and kind of come out on the other end and made some mistakes and learn from them. Just as a reminder, there will be a survey that's going to go out. Please fill that out. That helps us do this PD 101 better each time we put it on. We will be doing another PD 101 sometime in the fall, and it will be in person, which is very exciting. So we will get that out in our newsletter as soon as we can. And with that, I hope everybody has a wonderful evening, and thanks for your time.
Thanks, Jody.
Thanks, Jody.
Thank you.
Hal?
Yes.
I'm
going to call you just a second.
Okay, bye.
Bye-bye.